Okay.
All right, so once you all begin seated, come in last. All right, so you haven't met me. I'm Brady. I'm your wellness coordinator for the town. Most of you all, I think I've met during the biometric screening. So this is our first lunch and learn for the year. I'll try to have at least 2 a month for you all. If you all have any ideas that you would like to listen to or topics that interest you wellness wise, please let me know. I have them scheduled out through May so far. So like I said, if you have any ideas, I'm here to reach out to somebody. It will be meaningful for you all. So this month is February American Heart Month. And so I asked my dear friend Spencer, I said, I think I have a favorite. I've worked with him for years and years. So I had a favorite I think I could call in and have him come a little bit and talk. He is with Ballad Cardiology under Dr. Whitaker in the office with him. So, and he's just a good old country boy. He worked at Tacoma with me for years as a hospitalist too. So he is going to come talk to you about heart rhythms, risk factors associated with that, and so I'll let Spencer take it over.
Hi. So like I said, Brandon said, I'm Spencer. I'm a cardiology nurse practitioner. I thought this was going to be an open for everybody that I've answered any questions you all may have. A little bit about me. I'm from Gray, born and raised in Johnson City. I have 3 kids. We live out in Afton. Started a chicken farm this year, just to keep them active and busy with me. I worked in cardiology for almost 15 years as a floor nurse, and then progressed to a nurse practitioner. And, once I graduated, I moved to Greeneville. That's where I met Brandon for a few years as a hospitalist and transitioned back to cardiology. So I worked in Johnson City for about 6 years, and then we started having kids and needed to get closer to home and transitioned from cardiology to Johnson Medical Center. I've been here at Laughlin, or I can't keep up the name of Greeneville for 3.5 years now, I guess. So I specialized in general cardiology, but previously I worked in electrophysiology, cardiac rhythms. I do everything. Don't mention anything. General cardiology, heart disease, heart attacks, pacemakers. We do it all. So I'm essentially out here for you guys to, Q&A session to answer any questions you may have. I'll get back to Brandon. I'll fill her in and get you all taken care of. So, y'all have any questions particularly I can help? Risk factors? Heart attacks?
Y'all have your biometrics, so if this, your blood pressure is high, if you want to know about anything like that, it's a good time to ask Spencer.
What kind of symptoms? I'm sorry, symptoms of what?
I'll do first. I guess heart rhythms, atrial fibrillation is the most common heart arrhythmia or heart rhythm issue that we face. Atrial fibrillation, the biggest concern with it is when the top part of the heart is beating irregularly, these clots can form and they can get pushed out of the heart through these vessels called the carotids up to the brain, in which we have stroke. So the biggest concern for atrial fibrillation is in stroke. In most cases, you'll hear people talk about blood thinners like Xarelto, Eliquis, Pradaxa, Coumadin, and warfarin. People call it rat poison. We had someone diagnosed with atrial fibrillation. The biggest thing we hear complaints of is I feel like my heart is pounding, like there's a gerbil or there's a butterfly in my chest and it won't quit. And they can develop shortness of breath, dizziness. In some cases, people pass out, chest pains. It's a gambit. And one interesting case I had when I first moved down here, I had an 80-year-old gentleman just come up for a routine visit. He had a history of heart attack and open heart surgery. And I got an EKG just for routine management in the office. He had new onset AFib and didn't even know it. It's a gamut of people with symptoms. I have people right here I just mentioned didn't have anything. Fortunately, we caught it, talked to him about atrial fibrillation management, put him on blood thinner to prevent him from stroke. And then you have these, what you call frequent flyers that then come to the ER regularly because of symptoms of their heart rate's going so fast, causes their shortness of breath, chest pains, etc. So, AFib is the most common arrhythmia or abnormal heart rhythm that we see routinely in the hospital systems, and it's a big financial burden, and admissions are out the wazoo. Chest pains, the symptoms for that, you typically hear sort of heaviness and pressure. That's the biggest concern. That's a classic symptom for me. It raises my eyebrows. Someone coming into the office and saying, Spencer, I was cutting some wood, or I was going out, climbing up my hunting shed, I don't know, whatever. They climb up and they're doing something exertional, and then they felt pressure, tightness, goes down the left arm. I broke out sweats. My jaw was tingling, and then when I sit down, it goes away. And that's the classic symptoms that you have for heart disease, or chronic issue. There's always those gambits of diabetics. Diabetics don't have typical symptoms. Sometimes they just complain of fatigue, breaking out sweats. Women are just a whole other ballgame. They do not present the same as men in general. The symptoms that really worry me for workup is getting more short breath, just doing simple tasks like playing with my grandkids, playing basketball on Sunday evenings with this group of guys, have to take breaks, shortness of breath, and just walking from the kitchen to my and then the chest pressure, tightness, jaw pain, that deserves workup. A good thing that I work for Ballad, and one of the screening tools that we use, and it's available for anybody who don't need an order, you can actually order it yourself, is something called a calcium score. And you probably see these bulletin boards through town that say calcium score $49. It's a great tool. It's very inexpensive. The reason I say that, we have some family friends that live in Salem, and we had the friend is 65 years old. His brother had a heart attack recently. He said, I need to get screened. He went to Winston-Salem hospitals. They were over $250. So that itself pays, it's so affordable. The calcium score itself, the purpose of it is it looks at the plaque or a hardened plaque inside the heart, these coronary arteries. The discriminating thing is there's different types of plaque. You have hard plaques, which is what you can typically see on CT imaging, but the caveat is it doesn't sense the soft plaque. So there's discrimination in that aspect. The calcium score, $9 to look at the risk factor of, hey, where am I involving it? The big one, where does that put me? The calcium score can give you some direction.
And you will, I'm sorry, not to interrupt you, but if you get that, if you bring me a copy of it, you'll get wellness points just like you do for your colonoscopy mammograms, like your annual type things. You get a one-time wellness point for that.
What was it called?
Calcium score. Calcium score. Go. If you just type in calcium score, Ballad Health, it's going to give you this information for this number. Once again, you don't need to see your provider to get that. You can schedule it online yourself.
Just blood work?
What's that?
Is it just blood work?
It's a CT scan.
Okay.
It's a low-dose CT scan. And so I'm not sure. I've heard a gray area for people that if a provider actually does write the script, it's covered by insurance. I don't give you that.
So if you do that and it shows that you got higher, what's the next step?
So suppose you come and get a calcium score of 60. Calcium score, anything less than 100 is fairly easy. The higher the number, the more worse. It raises eyebrows and concerns for providers if it's greater than 400. Okay. So that's the basic numbers that we look at. Anything less than 100, fairly low risk. Once it creeps above 400, then you need to most likely refer to cardiology for discussion. Work out and how you feel, look at your family history. So family history, and one of the biggest risk factors, you can't control genetics. I mean, it's what you're born with. Obviously, nobody's really done smoking, tobacco use, high blood pressure, obesity, diabetes, high cholesterol. Those risk factors for heart disease. You can do everything under the sun to be active, and let's say you go to your screens with the health department or with what do you call it?
We call it biometrics.
Biometric screens, and they find your cholesterol continues to be high, and you get frustrated. It's not necessarily your fault; it's just genetics. AFib, another risk. That's another thing. For risk factors for AFib, prior history of stroke, untreated sleep apnea, family history, large amounts of caffeine use, large amounts of alcohol use, large amounts of stimulants. Anything those it's job security for me when anybody says they come in the office, they drink those baby pops or Celsius, or if they're colorful and pretty, they're not good for you. They're not good for you. But they keep and our heart's taken off now, and this, that, and the other. So I don't know the things are wrong.
Like the Lonnies and monster drinks,
Yeah.
all these high caffeines, 200 milligrams plus.
We got lawsuits. Red Bull's third. But I'm here for you all to answer any questions. You can easily most difficult. If I don't know it, I'll tell you, and I'll get you the answers.
I've seen that women could have different symptoms. Not many women in here, but they have wives or daughters and things. What should we look out
I'm
for?
sitting down with some apple. I have a patient myself. The only thing she's complaining is reflux. And if you can't see it.
No, I think we're good.
She's complaining she was taking Pepsi and Prozac like candy, didn't go away. And then she was driving to work and she was crushing chest pains. And then she had a full-blown heart attack and she had to fall off. Healthy 40 years old.
Mhm.
But different.
So anything out of the ordinary, just talk to your doctor maybe.
Yeah, I think we just had a candid conversation. The typical symptoms, like I said, pressure, tightness, they're not the same for women. Some people could just be gardening or just worn out. Or just climbing upstairs and say, this is not difficult for me. Just get exhausted. Other screenings, is there anything else that's covered or about?
We do A1C, cholesterol, the whole lipid panel, and then height, weight, BMI, stuff like that.
So I'll touch on cholesterol because I don't know if people will be correct. Ask what are good numbers for cholesterol? There's 4 parts of cholesterol we look at: triglycerides, LDL, HDL, and total cholesterol. Those are the 4 numbers we follow for screenings. The best way to remember LDL and LDL, you want the lowest possible. LDL, you want those numbers. HDL, heaven, you want those to be the highest. Total cholesterol, the average for something to be a good overall cholesterol total will be around 200. And the triglycerides, it varies, but I would say around 100 to 250 is okay in my book. Question is, what do you do for cholesterol numbers? I myself, I don't have a history of heart disease, but I don't know if it's our brains. The newest research for cholesterol management is European guidelines pushing for the, if you had a family history, if you had risk factors, and statin recommended, even at a low intensity, just to help lower the risk. So I have a friend, he plays soccer at collegiate level. He's been on Crestor, which is a popular cholesterol medicine. He's been on cholesterol medicine Crestor for 20 plus years, just because of the fact that although he's healthy and plays, he's got extremely high cholesterol numbers and family history, so he's been on it for.
Is there any, side effects to the Maden and statin?
It's a whole gamut. It's, you know,
What's your most common one that that people complain about?
forgetfulness, feeling like she's asking about side effects with cholesterol medicines. There's a whole gamut. The biggest complaint is muscle aches or pains. That's like the textbook thing people complain about. I have people that have been on it for 30+ years that have never been on it on the highest dose, and then I have someone who's been on it for 2 weeks at a low dose, and they just can't sleep because their legs are just cramping at night. It's just a whole gamut.
And then the longer they're on it, do they go away after a while? Like,
I can't say for sure on that. If it hurts and they're having muscle aches or pains, I usually ask them to take the medicine every other day. If there's any difference, then stick with that method. CoQ10, I don't know if it can help with that cramping feeling. The fancy term for it is called rhabdomyolysis. But if you look at CoQ10 at Walgreens, it's sold everywhere. And like side effects, forgetfulness, people feel like they're drunk, especially in older populations, elderly folks, forgetfulness.
it's just by looking at the numbers that I've seen so far, I've only printed out, we've only printed out half of our, we do have a lot that's got cholesterol, it's kind of all over the place, and
And most general practitioners, they don't treat cholesterol issues unless that LDL is above 130 and that total cholesterol is higher than 200. You have to look at the risk factors for each person. Everybody's different. So if you're fairly active, you don't have high blood pressure, then they may let it slide. You just have to have a conversation with your general practitioner saying, where am I at? I'm aggressive. That's heart disease is a real killer in the United States. It's not going away. I treat most patients with cholesterol medicine for risk stratification. You saw statistic, just have a conversation.
is there anything they can do diet-wise?
If you look at a Mediterranean diet, that is the most healthy and effective diet out there. There's 3 populations, I can't remember. There's 7-day Adventists. There's a island in Cyprus or in the Mediterranean Euphrates that they have the longest life expectancy. 7-day Adventists. They have the highest long life longevity because of their diets.
Is it called the blue zones or something like that?
What's that?
Blue zones, something like blue zones.
High fat, high cholesterol, obviously, if it tastes good, fried, obviously, it's better for your wallet. The textbook is 120 over 80, but the new guidelines are saying 130 over 80. So if you are diabetic or you have underlying kidney disease, they're going to be more aggressive with keeping those numbers low, around 120. Sleep apnea. I see sleep apnea about every patient for everything under the sun. I'm really aggressive with that. Signs and symptoms of sleep apnea, fatigue, daytime drowsiness, you can't concentrate, you're drowsy, you can just be sitting on the couch watching whatever program and just nod off. Big necks, 40 centimeter, or not 40 centimeter, but a large neck, large circumference, abdomen, the belly, what else? Can't concentrate, depression, you feel like you wake up and you've got 8 hours of sleep and yet you feel like you go right back to bed. That's the biggest, those just do for sleep apnea, weight loss, giving a sleep study. The newest thing on right now is actually home monitors. I haven't actually monitored that, but most people at this point have smart watches or pulse oximeters where you check your heart rate and your oxygen. There's an order that you can actually go under this monitor that measures your heart rate and your oxygen. You don't have to do a full sleep hospital. This monitor, you have to download an app. Where this monitor that goes on the fingertip, and it measures your breathing heart rates. And then this data is then uploaded to this app on your phone that goes to our sleep center, where the sleep medicine doctor, Bakshi, very involved in this area, is the first doctor. He reads that, so you don't even have to go to the hospital to get a formal sleep study. You can do that from home. Question they ask you, how do I get that? I don't think in the office, I don't know what, I don't know, biometrics can do that.
I like to ask Ted if that's something he,
They're widely available.
those symptoms for sure, let Ted know or your primary care doctor know, and then see if that's something you want to get. Yeah, it's not the old style where you had to be hooked up to
All
all
the
the
sensors on the head.
wires and all the
You're not gonna
things.
get sleep.
And your wives will be so much happier if you just get a sleep machine and put snoring in their ear.
What about the implant?
You're the Inspire. So they are only putting like ENT. I'll be. And I'm talking to a few pulmonologists, sleep study docs, and they say the evidence is just not there yet. I mean, the purpose of the Inspire plant that stimulates the diaphragm. When you quit breathing, it kicks that diaphragm drag, and your lungs start breathing again. On paper, it sounds great, but I don't know if this is the first one. Patients that have this happen. If you don't know, it's going to happen 10, 15, 20. So we call something come out and be on the commercial. Did you have the Inspire? Did you have a doctor? You have a just pay for some money. It's called a lawyer.
So is the main way to treat sleep apnea still the sleep machines, or is there any way around that?
It's a loaded question. Brenda Freed is a nurse practitioner who's she's the mid-level provider who helps write sleep studies, CPAPs, BiPAPs, options. She's the go-to.
Yeah.
She would be great.
Okay, I'll write her name down, I'll get her.
Because most people complain about that, about it's not comfortable, or,
If they complain about that with me, but at the same purpose, my job is to present you all are with the hospital.
Yeah.
And I just say,
You gotta wear it,
you
yeah.
gotta wear it. I mean, you're gonna be shocked, and they say, this is crap.
Yeah.
Insurance, who is it?
The main, the mask, a lot of people I was like,
Well, now they have some different ones too, they have some nasal
There's
ones.
slimmer ones now.
Yeah.
I think you can get the room. Who's the, where you?
Do you have one?
no,
Oh, okay, yeah. I get confused, like I know Liz Care, they use.
I'm used to it, I wear a mask.
But you see the bulkiness of it, there's new devices that, I mean, it just goes over your mouth, I mean, they're so small now.
Yeah.
Or is it something that goes in the nose and there's more of a nose breather? Dr. Bakshi once told me about sleep apnea, he said that if you don't wear the machine, like every year that you go without the machine, it's so many years off your life.
It's a silent killer.
Yeah, that's what he said, it's a silent killer.
Raises untreated sleep apnea. Raises risk for sudden cardiac events, stroke, all those things. Because if you think about it, if you're not breathing while you're sleeping, your body is fighting to stay alive. It's not getting oxygen. It's not getting that vital nutrition needs. Silent killer.
Yeah, I think it was like for every year that you don't wear it or you don't treat sleep apnea, it was like 5 years off your life, basically, because it was a silent killer. Because it leads to so many other health problems.
And suppose, let's say that you don't have sleep apnea, let's say you have that workout with the general practitioner or that sleep study that you have at home is negative, and it says that you have no apneic events, then what, and you can say, well, why am I feeling so tired? Things that you have to look at and have a conversation with them. One, we have depression, we have stress, in most cases.
Yes.
That's most anybody out there.
Check.
Check. Is your thyroid functioning properly? Do they do that?
We don't do thyroid. Some people have asked that when we do them, if they ask, but it's not a routine, something that I look at.
Getting your thyroid checked for disease is a good idea. And then, are you anemic, low blood counts, low iron? I don't know, what's the thyroid?
No, we just do cholesterol, A1C, basically on thyroid, yeah. Before the triglycerides, so before.
A comprehensive blood work will go a long way. Check things off to see what can cause it. It's just not one set thing, it's the whole entire picture.
I know it's not as common, but sometimes we read about children or young people that have cardiac events and sporting events and things like that. Are there things that parents need to do to, beyond like a physical that they would get for sports? Is there other things we need to do?
Pediatricians should do a thorough evaluation for physical parents, congenital heart disease, or birth defects, sudden cardiac arrest, families, premature birth. All these things raise the risk of these. We hear about these unfortunate cases, kids going down. And what was that guy's name? That got hit, Buffalo Bills player.
Oh.
That was just a once in a lifetime.
He is going to get right at the right
Right
place.
position, right time. Cardiac arrest. The pediatrician, you have those are really good things to screen for and have a conversation with pediatricians. It should ask for sports events, family history of sudden cardiac arrest, heart issues. Was your child, was he or she born prematurely? Genetic testing, that, I don't know, I was.
Yeah, no, that's good. Mhm.
My son, we found that he had high blood pressure. He was only 15 at the time after his sports physical. Well, I thought he'd been working out or whatever. And then we checked it after that, and it was still high. Come to find out is because he was chugging these like IV hydration drinks because he was sweating at football practice or whatever, so he thought he needed all these IV hydration drinks, and they literally had so much sodium in them that he was, that's why his
You get swole.
yeah, he was a little swollen. And so, of course, we talked about the pediatrician and did some food journaling and kind of his blood pressure and figured it out that, and it taught him more how to read the back of the label of what you're putting in your body. He just thought he was doing the right thing because he was sweating, so he was just chugging his drinks. So
The more.
yeah. Like,
Have you had any patients come to you and say, I did a genetic testing online and I don't have any symptoms, but I've got, this, and you were just mentioned genetic testing and.
I have referrals all the time, patients that are on screen. I don't have specific genetic testing.
Yeah,
Recommendation. Most times we just start with basic cardiac testing, echo program, which can give a lot of hints of genetic predispositions, heart disease or structural heart issues, valve. It's in the heart muscle. The echo program is also important. But I have referrals all the time because they did some type of screening of genetics.
Yeah.
Most times they have a family member who have and they're worried that.
yeah.
there's one.
and I know a lot of things, like with sleep apnea and stuff, a lot of it is weight related. It's like you said, it's bigger. Yeah, there's two different kinds, but some of it can be just by losing a little extra weight and more diet control type thing.
Okay, so you got all the weight on your shoulder, you're obstructing your airway all the way. And,
Anybody got anything else? Well, we got his attention.
if you are in close medicine, don't give up on it, don't just quit. They're very good drugs. If you're having that muscle ache or pain, either you cut back, let's say it's a 10 milligram, cut it to 5 milligrams and take a half a tablet versus just saying this stuff is killing me. The research is there, it's a great drug. In most cases, insurance is paid for it, it's affordable. But the truth is, it's in the pudding. Drugs are great medicines. CoQ10 is a great addition. If you're having that muscle ache, to take an addition to help offset that. But if you do actually have muscle ache, and you've been on different doses, different types of medications, there are other alternatives outside of that statin class. So don't just do it. It's a risk factor. You've got a family history. It's there.
Is visual still recommended? I don't see any people on visual with my YouTube.
Well, well, I
Well, I know, but I'm just saying, used to, everybody went on visual, it seemed like, and I've not seen it as much.
the smell of the reflux Belgium.
But for a long time, it was like everybody had it on their med list, and now I think it's now it's away, so. People better.
It's each your own medication. No problem.
What about statin and the link to the district? What about statin and the link to the district?
I still follow the ACC guidelines. We have to follow it. This is the only thing we have right now in our tool belt to help prevent sudden cardiac arrest or another repeat heart attack. Keep the stents open. You have a hospital, avoid stroke, avoid damage from diabetes. I follow the guidelines. You know that for me personally, I think that's a small risk that I'll take for the span of my lifetime.
I'd rather that one.
I mean, it's
Yeah.
in cases I've seen, again, I had a conversation internally with yourself also.
I still say statin.
So if you heard me earlier, even though if they fail, you can't handle them, there are alternatives out there. And there's these injections I've seen, if you've seen on TV called Lequio, Repatha, Prior. These are injections that you actually inject. It depends on the drug, but it's every other week. You grab a shot back, and it's a cholesterol medicine that insurance will cover if you have tried, let's say, Pravastatin, Rosuvastatin, Torvastatin, Pitavastatin. If you can't handle muscle aches and pains, the insurance will hopefully you have enough ammunition. The insurance practitioner will say we can't use these medicines. Those injections qualify for them. So even though these medicines may not work, there's, like I said, there's no one's out there that explains for just effective for risk.
Is there medicine to get like your HDL up? Is that the big, or is it
The heaven one, yeah. What's up?
HDL, low HDL typically, you can help individual that's still low for the genetics, but statins are they help ways that good.
I'm on statin, I'm not good.
Also exercising too, is that something?
That's what they always tell me.
Exercise.
But
You do
at the end of
a
the
class
day,
probably.
reality kicks in, it's nothing necessary that you're doing, it's, I mean, for exercise regularly, it's still not going out, you're looking at genetics.
I have bad genetics.
So, there's more of it, we can.
Things we can control, and then there's some things we just can't.
I have a patient, he's a cook, he's been on, he's all healthy, clean eating, all organic, no preservatives, etc. He had a heart attack at the end of the day, and he said, I don't because it smokes, doesn't have risk factor. I'm passing him by. I never forget this year's guy was Johnson City, and he's been doing research on his on the diet, 'cause he's a chef, and his HDLs have never gone up. And it's just been down and up, and it's bad. It's not you, with your parents, and you can't control that.
Mhm.
So it's more important.
I'm sorry.
So keeping the low LDL is more important.
The push right now, European guidelines, if you have risk factors for heart disease, heart attack, they're saying if you want the LDL less than 70. That's what European guidelines are pushing. If you have an actual heart attack, the LDL goal, if you have a stent or have bypass surgery, or you have high risk of having one of these, the pushes have an LDL less than 55. But this is the newest push in healthcare right now. It's getting that LDL lower.
Did they recently lower that number?
It came about 3 years ago. It's been in place for,
3 years?
yeah. It's been out there.
Your baby got your Ballad app and see what your cholesterol.
Yeah.
And all of our, we can't see all of our, because it's Ballad Clinic, it does all show on my chart. So if you've not spoke with me yet, I will meet with you all to go over those in March and first of April. But you can get on the Ballad My Chart app and see your results already.
And that is the dementia risk of status. Once again, the common side effects I see, forgetfulness, they feel like they're drunk. He or she, they feel like they just can't concentrate. These side effects are not permanent. If you stop the statin, the muscle aches, they will go away. The memory impairment, it will go away. It's not.
And at that time, you just usually change which,
You lower the dose or change the frequency every day.
if they have it, like, let's say they have symptom with like rosuvastatin, for instance, or whatever, do you just change them to another one? If you try to lower it or change the frequency?
The ones I think are practice more trackball and the Crestor, those are the three that's. Whatever insurance company, just look at the numbers and see if the medication works.
I know they have Crestor over at the office. Because most of them, I think, they get prescriptions for free over
The
there.
Crestor was great.
Every time cholesterol. Every time cholesterol.
Total cholesterol, less than 200, right around there. The LDL, if it's less than 130, no risk factors. General practitioners usually won't push it. But I'm different, I'm aggressive cardiologist. We want the LDL less than 70. If you had a heart attack, not surgery, stroke, LDL will be less than 55. We'll keep pushing it.
If you all feel comfortable, who in the room has had a heart attack that you know of? Anybody in here had a heart attack? I mean, if you don't want to share, you don't have to. I'm just curious to see. You have a heart, Tim, no,
I understand the whole heart attack. My heart attack was, hard, real bad, real nasty. Little shortness, right?
And that's important, is always hold on to what you felt, because people are going to say you're not having pressure tightness, but that's your story. I mean, you're going to, you know it, you're never forget it. You're never going to forget it. And you know your symptoms, you know the difference, because this is where I at.
I got heart disease both sides of my family, so I'm not.
You got that.
you got them good genetics.
It's not going to kill it.
for cholesterol numbers to, like, we have our stats from year to year. We always do our February biometrics. Is it normal for them to go up and down like that, or should I? Mine were high this time, and last time I had them checked, I didn't have any problems. So, yeah, right. But it's normal to see them kind of move around a lot. Okay.
What do you feel about?
Well,
You, go ahead. I just had a.
It's very wide. It's probably want to stay on the ground. And I see, we get patients all the time for cholesterol management, what we do, get frustrated because they tried everything on the kitchen sink and they can't get their numbers down, they have side effects from it, and we have to take over those injections for patho, right, Lakeview. So have you all seen those commercials for Lakeview? The newest.
I think I've seen anything.
So it's expensive. It's gone off of it. Benefit, you don't get an injection every 6 months.
Oh, okay. Well,
So
that's
it's convenient for people that need to inject it.
nice. And they don't want to take a pill every day.
And so it's medicine, medication, only can't city or needs for getting injection.
So what about probiotics? Well,
It's not an ACCI. I'm not discouraging, but it's not years.
have you had any patients that tried it and
I have seen this.
it's like that
The
Olestra.
Zepbound for the sleep apnea, I have seen that option to not, but it's more weight loss. I think it's more.
So funny thing you asked. So set down, we'll go with Manjaro's, Ozempic, Tirzepatide, semaglutide, all those weight loss drugs you see on commercial, the GLP-1s, they are game changers for healthcare and wellness. I mean, they're weight bypass, gastric bypass surgeries. And then the weight loss, you've seen it, but it's for diabetic management. The second tier is for weight loss. In years coming, I would not be surprised that cardiology will be prescribing themselves. It's in the research. If you get the weight down, you no longer risk of everything else. So it's catching up for most people in the hospital is getting it covered by insurance. Diabetes, if you have sleep apnea, they're both covered.
Yeah, I know sleep apnea, you can
Sleep
get
apnea.
that bound is like 100% coverage if you have that because of sleep apnea.
They're game changers. And then, in regards to risk, long term, they've been out for a while now. There's liraglutide for listening. I mean, that's been in practice.
The only thing I haven't seen is like, I'm not here, I work in the emergency room. The only thing I've seen is a couple of times I've had some people with pancreatitis, but they probably got other risk factors or whatever, but I've only had like 2 and then.
Well, and on top of that, these small bowel obstructions, people coming in with nausea, vomiting, pancreatitis, many, not all cases, but these people go to med spas, not saying one or the other, but people want instant satisfaction, gratification, results, and they start dosing, and they just increase the dose too quickly, and your body can't tolerate it and adjust, and then you end up with vomiting, feel like hell.
Yeah,
The right drugs have used the program. It's the best loss is slow and steady weight loss. We can do that.
any other questions? All right, thank you Spencer for coming. He's got a funeral to go to, so I'm trying to get my hair strong.